Welcome to JACC This Week. I'm Harlan Krumholz, Editor-in-Chief of JACC, and this is our issue for September 23rd, 2025. This week we explore a registry that may shift the treatment paradigm in right-sided endocarditis, genetics and heart failure prevention, the diffuse causes of myocardial infarction in younger patients, a major preoperative trial on blood pressure management, and a state-of-the-art review on stressor-associated atrial fibrillation. We'll also cover a brief report on long-term antithrombotic therapy after PCI and some fascinating case reports. And we begin with an editor's page on artificial intelligence, its promise and our responsibility to guide it. You may find that I'm doing a lot of editor's pages on artificial intelligence, but really that's the moment we're in. And I think it's important for us to be there with it. So this editor's page, Guiding the AI Revolution in Cardiovascular Medicine, I ask the question, I say, it's not really about whether AI will transform our field, but whether we will guide that transformation responsibly. In this piece, I lay out 5 guiding principles. First, start with problems, not technology. The best innovations in medicine begin with a clearly defined clinical need, not with impressive algorithms searching for a purpose. 2, insist on rigorous evaluation. AI must meet the same high evidentiary standards as drugs and devices, moving beyond accuracy metrics to real-world safety, efficacy, and generalizability. 3, prioritize equity at every step. Without representative data and fairness checks, AI risks worsening disparities instead of reducing them. 4, ensure accountability in deployment. Clinicians and institutions, not algorithms, must remain responsible for decisions that affect patients. And finally, 5, build systems of trust and connect to the broader ecosystem. Transparency, explainability, and clear governance are essential. AI should align with broader frameworks from professional societies to global health bodies, so it earns and sustains public trust. The promise of AI is immense. Earlier diagnosis, more tailored treatment, accelerated discovery, but its future impact depends on whether we uphold these principles. Okay, let's get to the original research. First, percutaneous mechanical aspiration for right-sided endocarditis. Elsa Bond colleagues report from the CLEAR-IE registry, the largest multi-center registry of percutaneous aspiration in right-sided infective endocarditis. They report on 256 patients at 19 U.S. centers. The median age was 43 years. Half were people who inject drugs, and more than a quarter had cardiac devices. Many had persistent Staph aureus bacteremia, septic pulmonary emboli, or large vegetations, patients who historically have had few good options. Procedural success with aspiration was nearly 90%, and percutaneous mechanical aspiration-related complications occurred in about 13% of patients. Overall, 18% experienced death, embolism, or urgent surgery. Numbers that reflect both the potential limits of this approach, but let's be honest, this is a very high-risk population, and high degree of outcomes that are really expected and unfortunately occur commonly. In their editorial, Quiliarello, Mehra, Spellberg, they write, "The moment has arrived." They emphasize that while antibiotics and surgery have been pillars for decades, the changing epidemiology, driven by injection drug use and devices, demands new tools. PMA, they say, is no longer just salvage therapy. It may become part of the future standard. Next, polygenic risk score for heart failure. Haller and colleagues analyzed nearly 75,000 individuals pooled from 6 major trials. A validated heart failure polygenic risk score predicted new onset heart failure even after accounting for clinical variables and NT-proBNP. The findings were consistent in both high-risk patients and low-risk cohort followed for 20 years. So what does this mean? Well, genetics can reveal hidden risk. Patients who appear healthy by traditional measures may carry high inherited predisposition. Identifying them earlier could shift heart failure prevention towards precision strategies. Still, Khan and Damarar caution in their editorial, "We're not ready to roll this out clinically. The study was largely European ancestry, lacked a true validation cohort, and raises practical questions. Should prediction differ for HFrEF versus HFpEF? How do we integrate genetics with biomarkers and imaging?" Their conclusion, this is a step toward personalizing the paradigm for prevention, but only a step. Nevertheless, we publish this because we believe it's a very important study. it's a very important step, and it's one we think that will ultimately lead to more scholarship that will change practice. The next study, myocardial infarction in younger patients. Raphael and colleagues present the Octopus registry from Olmsted County, capturing every troponin-positive event under age 65 between 2003 and 2018. Among 1,474 MIs, 2/3 were atherothrombotic, but in women, more than half were non-atherothrombotic. SCAD accounted for 10% of cases, yet was correctly diagnosed in only 1/3 of the time. Takotsubo syndrome, myocarditis, and embolic events also featured prominently. This study underscores that MI is not one disease in younger adults. For women, especially, etiologies diverge sharply from the classic atherosclerotic pathway. In her editorial, Harmony Reynolds stresses the stakes. SCAD is often misdiagnosed, and management's different. Conservative, not stents. She focuses in on this. She writes that better recognition of SCAD could improve outcomes and reduce harm. The next study, the BP Cares randomized trial, Zhao and colleagues randomized 1,477 patients undergoing major abdominal surgery at 3 Chinese centers. The trial compared intensive blood pressure management with a MAP of greater than or equal to 80 with conventional targets greater than or equal to 65 millimeters of mercury or 60% of baseline. Intensive management reduced hypotension exposure from a median of 8 minutes to below 65 millimeters of mercury to just 1 minute. Yet, outcomes were unchanged. No difference in cardiovascular events at 30 days or in secondary endpoints like non-CV complication, days alive at home, or death at 6 months. This trial adds clarity to confusing literature. It suggests the harm threshold for perioperative hypotension is around 65 millimeters of mercury, and that pressures above that are broadly safe. As the editorialists write, modern anesthesia appears safe from a hemodynamic standpoint. The real vulnerabilities may come after surgery, on the ward, where monitoring is less precise. We also have a state-of-the-art review, stressor-associated atrial fibrillation. Hamovich and colleagues synthesized emerging evidence on stressor-associated atrial fibrillation. Traditionally labeled transient, this AF occurs with acute illness, surgery, or other stress, but data now show recurrence and stroke rates rival those of other AF. The review proposes a framework. Some cases reflect underlying predisposition, or so-called provoked AF, and others are truly stress-driven, reversible AF. They identify unmet needs, better prevention outside cardiac surgery, better risk stratification for recurrence, some may be using AI, imaging, or genetics, and better patient-centered management, addressing quality of life and social determinants. The key message, stressor-associated atrial fibrillation is not benign. It requires structured follow-up and a new research agenda. We have a brief report, long-term antithrombotic therapy in AF after PCI. From the EPIC-CAD trial, we and colleagues use a win ratio analysis to study AF patients with prior PCI. Edoxaban monotherapy reduced adverse events versus dual therapy, mainly by cutting bleeding without raising ischemic events. The implications? Less may be more, even in a chronic setting. But guidelines still lack clarity for long-term therapy after PCI. Cases from JACC. Well, we present a few cases in addition. We had this percutaneous mechanical aspiration article on endocarditis, so we identified a few endocarditis articles. Fungal endocarditis of a prosthetic mitral valve, central retinal artery occlusion due to septic emboli, non-bacterial thrombotic endocarditis in antiphospholipid syndrome. You might take a look. These are great cases. They complement our original research article. So what did we learn here? Right-sided endocarditis is rising. Percutaneous aspiration is a promising alternative to surgery in high-risk patients. Polygenic risk scores can sharpen prediction of heart failure, though more work is needed before they enter routine care. Myocardial infarction in younger patients is diverse. SCAD in women is often misdiagnosed with real consequences. Avoiding hypotension below 65 millimeters of mercury remains critical in surgery, but higher BP targets don't add benefit. Stressor-associated atrial fibrillation is not transient. It demands systematic follow-up and new strategies for prevention. So I hope you enjoyed this issue. That's it for this week. Until next time, stay curious.